Now, when I started out in private practice, it was very much let's go through the motions with the subjective assessment, AGS, EASES, 24-hour patterns, blah, 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 rule out red flags, straight into the objective. And being completely honest, it was, okay, let's just get through that and then let's go to my favorite hands-on technique or my favorite rehab technique. Whereas actually nowadays, and we actually start to critically think. Hey, welcome to the Go-To Physio Podcast. My name is Dave O'Sullivan, and in this podcast, my aim is to give you 15 years of my experience in professional sport and private practice and share that knowledge so that you can get real world results with your complex patients who have failed traditional approaches. I hope you enjoy the show. Today, it is a HPP episode again. It's happy progressing patients, and it's a key concept from the book, and it's actually page 44 in Happy Progressing Patients. And in this chapter in the book, I talk a lot about that there is no magic bullet. Okay. Now, the second principle that I cover in the book on page 44 is the motor adaptations literature. So this is how to make sense of your patient's symptoms. Now, you're going to have a patient in front of you in the clinic, okay? So behind this wall here, there's a patient being treated at the moment, okay? And that's my promise to you, is everything that I go through in these podcasts, you can actually apply in the real world. It's not something that sounds great in theory, but you struggle to implement. Because remember, knowledge isn't power unless you can organize all that knowledge and actually apply it in the real world. And that's where I see so many people doing undergrad degrees, master's degrees, tens of thousands of pounds. They come through all of that and they have loads of knowledge, but they can't organize that knowledge and actually apply it. And that's really what we want to get into the nuts and bolts of how to do that today. And the motor adaptation literature, it's actually going to be important to help you make sense of what your patient is doing in the actual objective assessment, especially. Now, ironically here, you actually need to really understand your patient's story in the subjective assessment so that you can make sense of what you're seeing in the objective. Now, when I started out in private practice, it was very much let's go through the motions with the subjective assessment, AGS, EASES, 24-hour patterns, blah, 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 rule out red flags, straight into the objective. And being completely honest, it was, okay, let's just get through that and then let's go to my favorite hands-on technique or my favorite rehab technique. Whereas actually nowadays, and we actually start to critically think, you actually really need, and what I've realized is you have to have a very clear subjective assessment. So I will not go into the objective assessment until I'm very clear on the patient's story and it's starting to make logical sense. Okay, so taking the emotion out of it and the patient's story should make logical sense. Okay, so how we can make sense of the motor adaptations literature then, it's going to be all these things that they're doing. So if somebody's touching their toes and they maybe use an excessive hip dominant strategy, or the probably easiest one to understand is if someone rotates to the right. So if they twist to the right, you'll see their big toe coming off the floor where they may not want to load the big toe, okay? So again, the peroneals may not be wanting to produce force in that movement or may not have the access to that range or the kind of length in the peroneals as a result of maybe a previous ankle sprain. That might be just an easiest example to understand. So when we look at the motor adaptations literature, I talk about this in page 44, as I said, and I say here the second paragraph of that section is, in a nutshell, the motor adaptations literature shows when a noxious stimulus and or a pain experience is present, there are some important strategies the body implements to deal with this, okay? So from a protective mechanism point of view, from a survival mechanism, these motor adaptations, they're actually critical to help us survive, okay? But understanding them can be usually the key piece in the puzzle for patients who have failed traditional approaches, okay? So the next thing I go on to say in the book is there's no known predictable response to noxious stimulus and a pain experience, okay? Now that's a really important point to nail down on here, okay? There's no known predictable response to a noxious stimulus. So now all of a sudden we can't say for certain that, okay, their knee is driving inwards there in a valgus, that's because of a weak glute medius, okay? Now that actually makes sense when we step back and we think about that. There's no known predictable response that they've shown in the literature that two people will react very differently with the same noxious stimulus, essentially, to the, like usually they'll inject noxious stimulus into the knee joint or whatever, okay? Now, that makes sense when you actually appreciate the person's story. So for you and I, we might have knee pain, okay? Now, how I'm going to deal with that knee pain, I can start to offload the load tolerance or the ground reaction forces, I should say, through different parts of the body. Now, if I had a previous ankle injury, okay, then I may not want to use an ankle dominant strategy. Whereas if you had no ankle injury in the past, your nervous system might be happy to put excessive load through maybe your ankle, okay, or your gastro, your soleus, your Achilles. Whereas for me, if I've had an all ankle injury and now I have knee pain, I may not want to use excessive loading through my ankle, okay? So I'm training for a marathon, the Leeds Marathon at the moment, okay, for Rob Burrow, and I've had an all ankle injury. Now, interestingly for me, okay, what I'm noticing now is my right hip flexor and right quad is actually starting to get a little bit tight, a little bit sore, and fatigued as I go through the run, okay? And then it kind of all came to head at a 14-mile run over the weekend where I started to get really bad posterior ankle pain, okay? So the quad tightness came on first, then the ankle pain came, okay? So my working hypothesis there is, okay, well, if I'm not pushing well off my left leg, then I'm probably pulling more with my right leg, essentially, and then my quads starting to do a little bit more work. That gives a sensation to the spinal cord. That then eventually goes up to higher centers, and I have this awareness of a sensation that's unpleasant. It's not pain, but it's unpleasant through my right rec fem quads, okay? So that might be an example of how I am using a motor adaptation. Now, back to this, okay? There's no known predictable response. So what that means is our system and our structure is going to be even more critical, okay? So we need a way in our objective assessment to actually go, okay, well, there's no known predictable response, so I have to have a system and a structure in order to find that. So that's really the importance of having that structured system from your subjective to really understand and get all of this information and then bring it into the objective and actually start to make sense of why your patient is using these strategies to get from A to B, okay? Now, very often, a lot of the times what we're going to do with the patient in pain is we're just going to change the strategy. We're going to get other things to do a little bit more work. Usually the symptomatic area is going to do less work and the pain experience is going to decrease. From a rehab point of view, okay, and especially when we get up into pro sport and resilience, and we really need these athletes to go back and stay back, that's where all of these previous motor adaptations, we might have more work to do. Now, I always say in the mentorship is a lot of the times when I get somebody in for an objective assessment and I go to touch my toes, backward bend, rotate, all of these kind of low level, low tolerance movements, in my mind, you may not actually see some of their previous injuries kick in. But it's only when you get up, as you get closer to get them on the field again, you get into the high level rehab, bridging the gap from low to high level. That's usually where you start to see these motor adaptations really kick in. Okay, and you can start to see, like, why are they doing that all of a sudden? Or why are they doing that kind of funny movement? And then when you look back at the story, a lot of the times, 9 times out of 10, you're going to be able to make sense of it. So in terms of the motor adaptations, I'm going to say different people react in different ways. Okay, and that's why you must treat the person in front of you. Okay, you can't just have this, okay, well, if the knee goes into valgus, it's a weak glute med. I need to give him a glute med exercise, okay? Because what you might do is you might actually put them on the bed and put low tolerance through it, and they actually might be fine, okay? So that's where you have to look at the person in front of you. So then I also want to say activity of muscles above and below the area increases when degrees of freedom are reduced, or the nervous system wants to decrease stress on a certain part of the muscle or a joint. So activity of the muscles above and below the area increases, okay? So again, if I've got knee pain, I might start to use my soleus a little bit more, okay? Or I might start to use my hamstring or my quad or whatever, okay? So again, I don't want to say for certain it's going to be this or that, okay? Because the reality is we all have different story, we've all different structures, okay? And our skeletons are different, okay? So we're going to use slightly different strategies. Now, this is really interesting. When there's an option to offload stress on an injured area, we take it, okay? So then I said, this is implications for rehab when using 2 legs, okay? So what I mean by that is the most simple way to understand that is you'll see an ACL reconstruction patient, okay? So ACL rehab, and when they do a squat, they'll naturally shift over to one side, okay? Now, the reality is you're going to see that whether they've had an ACL reconstruction or not, okay? I remember running in the gym I was on that assault runner the other night. It's the absolute bane of my life. That kind of self-propelling treadmill kind of curve thing. Oh my God, nothing gets my heart rate up higher than that. And I was actually running, and as you do, you're kind of like looking at people in the squat racks and stuff like that, and being a physio, you're kind of looking at movement and stuff like that. And this one person, they were squatting, and the shift as they were coming down to the right was incredible. And I was like, why are they doing that? You know, and obviously I'm like, I wonder what's in their story to do that. So it doesn't have to be somebody that's had post-op surgery, but that's probably the most common one that us as physios are going to see, is when they squat down, you'll see they'll naturally shift to one side. So again, the question I want to ask is, why is the nervous system not happy to load the left side? What's in their story that's maybe causing that perceived threat that's ultimately getting a movement strategy that's shifting them a little bit to the right, okay? So that's an option. The next point, research shows when a noxious stimulus is present, the nervous system is capable of producing the same force through the knee joint as that prior to the noxious stimulus being present, but the direction of force through the knee joint changes, okay? So this may be a useful short-term solution, but long-term, what are the consequences, okay? So again, what I'm talking about there is in one of the research papers around motor adaptations literature is they measured knee extension, they injected a noxious stimulus, and what they found was the patient was able to produce the same force, but the difference was that the angle of load tolerance, or the force that they put through the joint, changed slightly. Now that's incredible, okay? So again, it's really useful to understand this because the brain doesn't really care, it just wants to get the job done, okay? But again, short term, that's fine, but long term, what's the consequences? So are we seeing the patient after the long-term consequences has caught up with them, okay? So that's really, really important. So then you start to ask yourself, okay, well, is that why maybe one part of the Achilles is starting to get irritated versus another part, okay, or the patella tendon, okay? So again, or is that, you know, why maybe the medial meniscus is getting irritated, or the lateral meniscus, okay? Again, you can't just say it's going to be X equals Y. We have to make it specific to the person, okay? Now, this is probably the most important point of all here, okay, from the literature, okay, is once the noxious stimulus is removed, the previous movement strategy prior to the stimulus doesn't necessarily return, okay? So then in brackets I say protective movement behavior remains. Now, that's really, really important because ultimately what I see with a lot of patients is actually, am I just seeing the result of this where actually the pain is gone now, but they've still kept a lot of these movement strategies, and are these strategies now starting to catch up with them? Now, when we start to look at this in a very simplistic format, we can start to say, okay, well, if they're starting to use these strategies, or they're continuing to use these strategies, then essentially what they don't have is they're probably not going to have a lot of good variance of movement and a lot of movement variability through these particular movements. So from our point of view then, and a rehab point of view, which is actually quite empowering, all we need to do is give back the nervous system an ability to tolerate load through these areas of the body. So a lot of my assessments, it's not about a diagnosis, it's actually about a shopping basket, as Louis Gifford said in Aches and Pains, okay? And I think that term is actually really good, that shopping basket, where you find what's not doing its job, okay? And then you go, okay, well, this isn't doing its job, or maybe this is doing a little bit too much work, this isn't doing enough. Let's give the nervous system back an ability to tolerate load. Now, before you dive into that approach, the critically thinking therapist will go, okay, what's the lead domino here? What if I can do this? Then I'm going to get a positive second, third order consequence, like I talked about in last week's podcast, okay? Second order consequences. Second order consequences could be good or bad, okay? So what can I do to influence the nervous system? Whereas if I do that, I'll get a positive second, third order consequence where a lot of these motor adaptations will undo themselves anyways, okay? So that's going to be the key thing, okay? The final point is the most important of all to understand. The nervous system may not go back to the previous strategy after the pain experience has been gone. And again, you looked at that Bullock-Saxton paper from, I think it was 1994, which is obviously quite a few years ago now for the keyboard warriors, but they showed that after an ankle sprain, the glute muscle activation was affected, you know, up to a year after an ankle sprain, okay? And then we can start to see there's some literature out there showing that, okay, if you've had an ankle sprain, you may increase your risk of hamstring injury as well, okay? And again, you know, does it make sense? It probably does, because again, if we're not loading that big toe, what's the second, third order consequences up the chain? Something else has to do the job. As we see from the literature, the nervous system is going to find a way to get from A to B, okay? I'm going to get my 14 miles done regardless, Okay, I may not be loading well through my perineals, but I'm going to find a way to do it. Okay, so again, I think this is an incredible area I think it's really important research, because I think we're seeing a lot of this stuff. And I think especially in pro sport, the amount of athletes that will come in and they'll say, oh, this just feels a bit tight or that feels a bit tight. In private practice, we tend to see patients when they actually have a pain experience or something like that. Now, you might get a few runners that say, oh, I just feel tight here when I'm running, blah, blah, blah. I'm still able to do it. Whereas the beauty of pro sport is you tend to see things at the start of the continuum. Okay, so it may not necessarily be a pain experience, but it's an unpleasant sensation. Okay, so again, that sensation is potentially a perceived threat. Okay, so again, the nervous system is giving you this sensation. It's not as severe as pain. Okay, and then if you were to go down that road and continuum, then if the nervous system wanted you to change behavior, which is one of the biggest jobs of having an unpleasant sensation or pain experience, then it's going to be sharp. Probably it's going to be quite intense, which is really going to stop you in your tracks. Whereas at the start of that continuum, that's how I see it in my mind's eye. Sharp pain, intense, that's going to stop you in your tracks. Whereas that unpleasant sensation is just starting along that road. Okay. Now, whether that's right or not, wrong, who knows? I could be wrong with that. Okay. But that's the way I think of it at the moment. Okay. So that's the key thing. Page 44, 45. Okay. Really, really important to understand the motor adaptations literature. So again, my challenge to you this week from a practical application point of view with this is, when you see your patient using some kind of strategy to achieve a task, whether it's a toe touch and they don't have a lot of movement through the rib cage, or it's something else where they're rotating, they're not loading their big toe, or they're doing something, they arch the back, rather than just jumping in with first order thinking and saying that's because of a weak glute or a weak core, step back and go, okay, what's in the patient's story? Why would their nervous system choose to use a movement strategy like this? Okay, and what's not doing its job, that if it was doing its job, that the pain experience would not be a problem in the first place. Okay, so that's it for this week. I hope you enjoyed the show. As always, I'm not going to put a lot of advertisements and advertising in the show. If you enjoy the show, please share the show. That's all I ask. Okay, if you don't enjoy the show, then feel free not to share the show. If you found it useful, if you got something that you can apply in the real world, if you got something that's a aha moment, then, as I said, just share it to a colleague. Say, hey, you might enjoy this. This actually helped me. Okay. In a world where physios are eating each other down and we're trying to push each other down and, knock each other down, I think it's a good thing we actually help another therapist. So as I said, if you got value from this, share the show. If you want to go one step further and you like the show, please give it a review as well, because that helps get it in front of more therapists who may need some help also. Okay. As always, if you want to get your questions answered on the show, head over to go2physio.com/questions. I'll be doing some specific episodes with questions in the coming weeks and months. If you want to pick up the book, Happy Progressing Patients, go2physio.com/book. We've got a special project that we're going to be releasing in the next month or so. If you've listened to this at the time of recording, this is February 2023. It may be launched by the time you listen to this. Head over to go2physio.com/members. That's for therapists who aren't quite ready for the mentorship program. If you want to get a structured step-by-step system to have the clarity and confidence to keep any patient progressing in private practice or pro sport, then head over to go2physio.com/mentorship. If you don't want to mess around, if you don't want to take years figuring stuff out and making mistakes, if you don't have to spend tens and tens of thousands of pounds on undergrad and masters and not be able to apply the knowledge, then the mentorship program will help you do that in the most simple and direct path. I've done it for over 1,000 therapists. As I said, usually I'll have a call, a chat, see if it's a good fit for you, and if it's a good fit, then I'll answer all your questions and show you around the mentorship members area. Okay, that's it for this week. As I said last week, make sure that you solve big problems for your patients. Step away from this whole look at the side of pain, just give them a lot of exercises that they have to do on their back. Look at the person first, pain second. Make sure you understand the problems that the pain is causing the patient, and then put that front and center at your treatment plan. Give the patient stuff that's going to solve their problems. Okay, have a great week. We've got probably the best job in the world where we can make a massive impact on patients' lives. So let's get to work and enjoy working with happy, progressing patients.